So I'm going to turn to my topic for today, which is long-term outcomes for Ibrutinib and idelalisib. I do want to acknowledge three of my colleagues, Jennifer Brown, Susan O'Brien, and John Bird, for providing me with some updated data on the long-term outcome for some of the key trials. I also want to thank my colleagues at Mayo Clinic, Samir Parikh, Tim Call, and Wei Ding for helping me in putting this talk together. So the learning objectives for this talk are three. The first two in particular: what clinical trial strategies have been conducted that have tested the long-term outcomes for BCR inhibitors, and to detail the pertinent clinical and toxicity outcomes for long-term administration of BCR inhibitors in upfront and relapse refractory CLL. And then finally, can current treatment approaches be informed by analysis and knowledge of these trials? I have to make a few editorial comments. One is that this is one talk in a series, as you can see, that the organizers have put together to help us formulate how we look at our clinical opportunities and look at also and manage the toxicities. In terms of long-term, I think we have to look at that with a bit of a grain of salt. I mean, these updates are anywhere from perhaps 3 to 5 years. To me, that's not really long-term. To me, long-term would be more something like looking at the incredible and outstanding career that Dr. Kanti Rai has had over the long term. Now that's real long-term validation of success. Never hurts to get on the good side of the session chair as well. So let me start out with long-term outcomes with chemoimmunotherapy. And I think it's important just to have one slide on this, but actually this is underestimating the amount of time that we've all spent testing CIT, and that includes FCR, FR, PCR, and BR. And we all know that the current data for that shows high overall responses with approximately 45 to 50% complete responses in the upfront setting. But there are caveats, as we all know. High-risk FISH and IGVH unmutated do not do well ultimately. There are significant cytopenias even in responding patients. But we've heard earlier, and we now know from at least 3 separate publications, that subsets of patients who are fit and have IGVH mutated and low-risk FISH can do extremely well over the long run. So we need to keep that in mind as we go through this talk. Now I'm going to be drilling deep in terms of the clinical outcomes and toxicities. Most of this data does, of course, come from clinical trials. You're going to hear more about the real-world experience from Anthony Mato and also from Jennifer Brown. Now, I think it's important to look at the history of the BCR inhibitor trials. This is the history of that world by myself. You have to understand that Ibrutinib was the first in human clinical trial, was the so-called Advani study, and that was published in January of 2013, just a few years ago. From March 2009 to September 2010, 56 patients were enrolled in 7 cohorts for Ibrutinib. And since that time, CLL patients in clinical trials estimated around 6,000 enrolled patients, and 70,000 patients have been treated worldwide with Ibrutinib. In regard to Idela, the first patient was enrolled in the initial Idela trial called 10102 on July 9, 2009 at the Sarah Cannon Research Institute. In total, all trials with a data cutoff point of July 22, 2017 are 1149. And the reason I put these numbers out, these numbers still, at least in clinical trials, pale compared to the number of individuals we put through CIT trials. Now, the key clinical trials that I would consider for a presentation that are Ibrutinib based would be PCYC, which is the initial single agent Ibrutinib phase 1b/2 in patients with previously untreated or relapsed refractory. It's a landmark study that showed for the first time high overall responses, and that trial opened in 2010. There's the so-called Resonate-1, which is a phase 3 comparing Ibrutinib to ofatumumab in previously treated CLL. It led to approval for relapsed refractory patients and for deletion 17p in 2014. And again, the Resonate-2 trial, which is a phase 3 frontline, Ibrutinib versus chlorambucil, led to an approval for frontline CLL in 2016. There are 2 other trials I'm not going to talk about that are important. The Helios trial with ibrutinib with and without bendamustine rituximab, we're adding ibrutinib to BR significantly extended PFS in these compared to BR plus placebo, and did get FDA approval in 2016 for that combination. And then there's a Resonate 17 that gave us further evidence of the efficacy for 17P. But what I'm really going to focus on are the 3 trials in the red square. In terms of key clinical trials for IDELA, there is 116, which was IDELA and Ritux versus placebo, and rituximab led to an FDA approval for relapse refractory CLL in 2014, and then the 115, which is the bendamustine rituximab plus IDELA versus BR alone, and that phase 3 trial did show improved progression-free survivorship compared to BR alone. There is a safety analysis phase 2 clinical trial for frontline IDELA in combination with ofatumumab, and I'm not going to talk much about that at all. Jennifer Brown will be giving you more details on that trial. So I'm just going to focus on those 2 trials for the remainder, those 5 trials for the remainder of my talk. So let's drill deep into the phase 1b/2 trial for relapse refractory and naive. These were treatment naive, which is 31 patients and 101 relapse refractory. They got either 420 or 840 mg per day in this initial trial, and they were treated and were able to stay on it with a stable disease or better, and then could go on an extension study if they wished. This did include high-risk patients, including those who had progressed less than 24 months after CIT. I highlight for you the numbers of patients. They weren't huge, but the median age more closely reflects what we might see in the community. ECOG performance status was reasonable. Many of the patients were in, the majority were in RI 3 to 4. And bulky disease could be seen more evidently in the relapse refractory. In terms of the baseline characteristics, pay attention to the red column there where the relapse refractory had sundry high-risk abnormalities, including complex karyotype, and 80% had unmutated IgHV. And the median number of prior therapies was 4. So it's truly a pretty tough patient cohort to be treating. Basically, the bottom line in this slide is that in the update provided for this study, there is a considerable number of patients that are still on treatment at the 5-year update. 65% of the treatment naive and 30% of the relapse refractory. In terms of best response at the multi-year update, pay attention to the right-hand side of the slide. The total is 90% with 14% CRs, but note that if you remember the original publications, the CR rate now for treatment naive is up to 29%, and for relapse refractory is at 10%. And the median duration of response has not been reached for the treatment naive. In terms of high risk, this is quite impressive. If you go from right to left, you can see that even in deletion 17p, the overall response is 80%. It goes up to 90 to 97% for relapse refractory complex karyotype. The unmutated IgHV is 90%, and 11q looks very impressive in terms of overall response with a 9% CR. What about survival by complex karyotype? In terms of progression-free and overall survivorship, it's not good if you have complex karyotype, but still the response, the duration of response was quite reasonable. In terms of survival outcome for the overall population, for progression-free and overall survivorship, being treatment naive obviously did better. Note the treatment naive, I think you may have seen this earlier, the 5-year PFS is 92%. As it is PFS, as is the OS. For relapse refractory, it's impressive, but still not, of course, not nearly as high as in the treatment naive. What's important about this slide is just to show you that over time, the adverse events that were greater than 3 seemed to dissipate. So you see the hypertension, pneumonia, neutropenia, atrial fibrillation at the less than 1 year, but you see it really diminish, except perhaps for hypertension at the 2 to 3 year time point. So just in summary of this important landmark trial, at 5 years of follow-up, durable responses for ibrutinib are evident in treatment-naive and relapse-refractory. For the relapse-refractory patients with 4 prior lines, the median PFS is 52 months. Certainly we couldn't be saying that for any other approach. And the overall survivorship has not yet been reached. And for treatment-naive, 92% of patients are progression-free at 5 years. The CR rate has increased over time, as I showed you. The survival outcome, however, still there are some genetic risks here. Complex karyotype or deletion 17p seem to be less robust. And ibrutinib, and I put this in, I highlighted in yellow, it's well tolerated with onset of most new grade and grade 3s decreasing over time. And as I mentioned, the majority of patients who are treatment naive still stay on treatment, and about a third of the relapse refractory patients continue on treatment. Now let's turn to the RESONATE. This is the first of the 2 phase 3s I'm going to present. In this case, these were relapse refractory patients who had to have at least 1 prior therapy, were not eligible for fludarabine-based therapy, and had measurable nodal disease by CT. They received either ibrutinib now at 420 until progressive disease or tox, compared to the intravenous ofatumumab schema you see there. And 133 patients on the OFA arm could cross over to ibrutinib if they had progressive disease. So patient demographics here that are important. The median number of prior therapies for the higher risk were 3, for deletion 17p and 11q were 3, whereas for no deletion 17p it was 2. And you can see bulky disease was evident in a large number of these individuals, so a pretty tough patient population. Just in summary of the 4-year follow-up presented at ASCO by John Bird, the AE profile was consistent with previous reports. In selecting some key toxicities, major hemorrhage was seen in 6%, atrial fibrillation grade 3, 6%, and grade 3 hypertension in 8%. Most, again, in this study, most grade 3 AEs decreased from year 1 versus year 2 or 3. And this is just some key toxicities to look at. Neutropenia, pneumonia, and atrial fibrillation all had some decrease. I think of interest, it was interesting that neutropenia seemed to be less prevalent, dropping 10%. Discontinuations, however, are still most frequently due to progressive disease in 27% and AEs in 12%. However, 46% of patients continue on therapy. The progression-free survivorship shown here is quite dramatic. It's obviously highly significant for ibrutinib over OFA. The median PFS has not yet been reached with a highly significant, statistically different value. In terms of genomics, this is actually a slide from Jennifer Brown's recent publication where the impact of, in terms of PFS, looking at genomics in general looks pretty good, but you'll note that the blue curve, which is deletion 17p or p53, Jennifer has pointed out to me, really still shows somewhat of a diminished PFS. Still pretty impressive, but maybe not as good as the other cohorts. So just in terms of long-term update for RESONATE-1, 44 months median of follow-up for ibrutinib versus OFA, significantly longer PFS, not reached versus 8 months. The 3-year PFS is 59% versus 3%. High-risk genomics, as I mentioned, the PFS does not appear to be impacted by known specific mutations, with the caveat perhaps of the 17p and or p53. The 3-year overall survivorship was 74%, and the overall response was 91%. Again, an increasing CR, 9% over time in the ibrutinib. So again, in conclusion, for the long-term results, I mentioned the sustained PFS and OS, the caveat of the 17p and p53, and again, this is sort of inconsistent now even with the original landmark study. No long-term safety signals have emerged, and many toxicities appear to be diminishing. Kind of a recurrent theme for these trials. Let's turn finally, in terms of the Ibrutinib trial, to RESONATE-2. Frontline therapy, these were 269 patients. They were treatment naive, greater than 65 years, or for patients 65 to 69, comorbidity that may preclude FCR. Deletion 17p was excluded. And these patients were given either Ibrutinib at the now well-accepted dose versus chlorambucil at the schema you see there. And they could go on, if they progged, to an extension study, and 55 actually crossed over to Ibrutinib following progressive disease. Now, in terms of patient characteristics, again, the median age is happily for this trial more consistent with what we see for typical patients. There was bulky disease in 44 and 30% of the cohorts, and unmutated IGHV was around 50%. So obviously Ibrutinib in this figure shows you a prolonged PFS versus chlorambucil. The median PFS has not been reached, whereas the median PFS for chlorambucil is 15 months. Ibrutinib prolonged PFS over chlorambucil for 11q, and you can see that for the Ibrutinib arm, whether they were 11q or not, they had equivalent PFS, and I think that Rick had shown you this slide earlier. What about IGVH, mutated or unmutated? Again, the yellow curves are the Ibrutinib, and you can see whether they're unmutated or mutated, very equivalent PFSs. In terms of overall survivorship, Ibrutinib was believed to demonstrate an overall survival benefit over chlorambucil with a longer follow-up, even including the crossover. The overall responses in terms of CR and PR are shown for you here. Again, these are data showing you, if you will, all patients on the left, 92% with 18% CR, but you'll note that with deletion 11q or not, the overall responses are pretty equivalent, maybe more CRs in the patients who didn't have deletion 11q, and then for the unmutated and mutated, pretty equivalent response levels, a diminished overall response of for the mutated of 88%. Most patients, again, remain on therapy. This is one of the continuing themes. In this slide, you're seeing that almost 80% of patients still remain on treatment. The most frequent AEs in the Ibrutinib arm are shown here for you, the diarrhea, fatigue, cough, anemia, peripheral edema, and arthralgias. You can see grade 1 and grade 3 AEs in the Ibrutinib arm. These are, and there were, fortunately, happily, very few grade 4 or grade 5 events. Toxicity, again, has been looked at in this updated evaluation, and shown here are comparisons less than 12, 12 to 24, and greater than 24, and you can see, again, this theme of diminishing events over time. So in summary of the RESONATE-2, the median time on study was 29 months. Ibrutinib continues high efficacy. That includes risk groups like a deletion 11q and unmutated IGHV. Responses improve over time, with 18% of patients achieving a CR or a CRI. The rates of treatment limiting AEs, including dose reductions and discontinuations, decrease over time, with, as I said, 80% of patients still on daily Ibrutinib. So clearly fairly well tolerated in follow-up. Currently, 66% of patients continue on Ibrutinib. I'm sorry, the initial line said elderly patients continuing on daily Ibrutinib, and 66% of all patients continue. So let me turn the last part of my talk to idelalisib. This is the 116 schema. In this case, it was a subgroup analysis presented by Jeff Sharman at ASH a few years ago, particularly looking at high-risk groups. And so this was placebo rituximab versus idelalisib, and there was an extension study in this as well. Jeff has assured me there will be an update coming soon, but basically what I want to show you is that these were patients who had eligibility criteria that would not be typical. They should not be appropriate for non-cytotoxic therapy and had fairly high SEER scores. And any grade anemia was allowed, and a Karnofsky score that was pretty high. So kind of a different patient cohort to be treating. What you see here that I've outlined in the red boxes are the total SEER scores greater than 6, and you can see that they're pretty equivalent for the placebo arm versus the idela arm. And the high-risk FISH unmutated IGHV were relatively equivalently represented in these two cohorts. In this waterfall plot, what you see is the lymph node response at the second interim analysis in idela plus rituximab, pretty significant lymph node responses in many patients compared to the placebo arm. In terms of progression-free survivorship, for all patients, the idela plus rituximab arm was the clear winner with a 19.4 month versus 7.3 month median PFS. The toxicities are shown here for you. The more common toxicities seen in more than 15% of patients included fever, diarrhea, colitis, fatigue, and cough. I think you're going to hear more about these toxicities from Jennifer Brown and Anthony Mato. The high-risk subgroup analysis I do want to emphasize, again, consistent theme here, that even for patients who have high risk, like unmutated, or who have higher risk, like deletion 17p, there appears to be an equivalent response. So in summary and conclusion of this phase 3 trial for idela Ritux versus the placebo, there's a comparable efficacy for patients who have high-risk genomics, including unmutated IGHV, deletion 17p, and deletion 11q. The overall survivorship was significantly better for patients who are on idela rituximab, despite even the crossover. And again, idela and rituximab have a manageable safety profile for patients with relapse refractory CLL. The final trial that I'll show you is a phase 3 115 study where two arms, one was placebo and bendamustine rituximab versus idela at the dose you see there. Also in patients given bendamustine rituximab. The enrollment period was for 2 years from June 2012 to 2014. Stratification included some of the high-risk cohorts you'd expect, deletion 17p, mutation, and refractory versus relapse disease. And these are the stratification factors in the cohorts, and you can see relative equivalency for 17p IGHV mutation status and refractory relapse disease. The conclusion from this trial are summarized here, that idela in combination with bendamustine rituximab was superior to BR alone with regard to OS in relapse refractory. The median OS had not yet been reached at the time of the initial of the analysis versus 41 months for the placebo arm. The improvement in the OS was observed across all risk groups, and the overall safety profile was manageable. The toxicity, some of the things that perhaps were pointed out, opportunistic infection, including PJP and CMV, were more frequent in the idela versus placebo arm. Again, I think this is a reasonable comment for these trials. This regimen represented an important option for patients with relapse refractory CLL. So I think this is my last slide, and basically is my attempt to synthesize for you how I look at these updated data. I believe that both ibrutinib and idela Ritux now have relatively long-term follow-up. Again, it's relative, but these are fairly intense analyses for these clinical trials, and you have to remember there are phase 3 trials in this group. The effectiveness for both is clear. Ibrutinib for upfront high risk as well as relapse refractory is there. For ibrutinib and for idela Ritux for relapse refractory CLL, we're seeing for both cohorts improved response rates over time. These toxicities are clearly evident. For the most part, they do tend to be low grade, but are chronic toxicities. They do not appear to be overlapping necessarily with CIT, and so I think we have enough data on this at this point in the long term to still feel relatively comfortable about the utilization of these approaches for our CLL patients. I'll stop there and thank you for your attention.